So welcome to part 3 of advanced monitoring for the ABA part 2 advanced exam. Had some new keywords this year just to keep things up to date. Added a section on inhaled nitric oxide, the use of nebulizers, echocardiography, we'll cover that briefly, as well as the use of pacemakers. Again, the ABA is kind of bizarre in the way it lays out the content outline for the part 1 versus the part 2 exam. I don't know why you wouldn't include nebulizers within breathing systems of the part 1 exam. I don't know why it's specific to the advanced content outline. Furthermore, defibrillators show up in the part 1 basic exam. Pacemakers show up in the advanced exam. Go figure. So anyway, let's jump into nebulizers and inhaled nitric oxide. I'm talking about nitric oxide pharmacology. Which of the following best describes the mechanism of action of inhaled nitric oxide? Yes, like it or not, you do have to memorize this for the exam. Is it activate guanylyl cyclase and increase cyclic GMP? Activate guanylyl cyclase and decrease cyclic GMP? Inhibit guanylyl cyclase and increase cyclic GMP? Inhibit guanylyl cyclase and decrease cyclic GMP? So you should be able to reason your way through this question. First of all, guanylyl cyclase, it's a cyclase type of enzyme, meaning it forms a cyclic compound, meaning it forms cyclic GMP. So either the answer choice has to be either A or D. In this case, an increase in cyclic GMP is the mechanism through which nitric oxide produces vasodilation. So that's just one of those things you're just going to have to know for the exam. All the following are side effects of inhaled nitric oxide therapy, except which one? Formation of methemoglobin, decreased platelet function, generation of nitrogen dioxide, and decreased systemic vascular resistance. The correct answer here is D. Inhaled nitric oxide is so rapidly neutralized in the bloodstream that it exerts its effect on the pulmonary vasculature, but it never really quite makes it to appreciable concentrations in the systemic vasculature to drop systemic blood pressure. That's what occurs with intravenously administered nitrovasodilators like sodium nitroprusside and nitroglycerin and things like that. But inhaled nitric oxide, the main advantage is that it doesn't drop your blood pressure, but it does sufficiently decrease pulmonary arterial pressure. Nitrogen dioxide is a byproduct of the metabolism of nitric oxide. It does form methemoglobin, and it is a known platelet inhibitor. So inhaled nitric readily diffuses from the alveoli into the vascular smooth muscle. It activates guanylyl cyclase, as we mentioned, increases cyclic GMP concentrations within the cytosol, and that ultimately leads to a downstream cascade of events that causes pulmonary vasodilation, largely due to the inhibition of the calcium effects intracellularly. There's no effect on systemic circulation, and the doses range from about 5 to 80 parts per million. So inhaled nitric oxide, about a third of patients with pulmonary hypertension show no response to inhaled nitrics. It's quite a fraction of patients that won't respond. They just have non-reactive pulmonary circulation, or they have far too rapid nitric inactivation. There may or may not be abnormalities of the guanylyl cyclase system, or there may be a rapid breakdown of cyclic GMP, which can be inhibited by the addition of dipyridamole. The main adverse side effects of inhaled nitric include inhibition of platelet function. Nitric oxide is something normally released from endothelium when platelets are activated. It's meant to stop platelets from forming plugs in areas of normal endothelium. But if you give it iatrogenically, it can also cause inhibition of platelet function. Rebound hypoxemia and pulmonary hypertension can occur upon discontinuation of nitric. Inhaled nitric can combine with hemoglobin to oxidize the iron atom in the hemoglobin within that porphyrin ring system to form a nitrosyl hemoglobin, which is readily oxidized to methemoglobin. Development of nitrogen dioxide. Now, this is significant. Nitrogen dioxide is the main metabolic byproduct that occurs from exposure to nitric oxide. Nitrogen dioxide is rapidly converted to nitric acid in aqueous solution, which is a very powerful acid. It's highly toxic to the respiratory tract. So increasing concentrations of nitrogen dioxide with high doses of nitric basically can cause cellular injury to the alveolar tissue. So this may result in pulmonary edema, increased airway reactivity, and this is what you have to watch out for when you're using this drug. There's usually in the nitric monitor you can also, there's a measurement for the total amount of exhaled nitrogen dioxide as well. And that tends to be the rate limiting factor in how much you can use it and how long you can use it. So I'll leave you to sort of pour over this image, which essentially shows you how nitric oxide makes its way from the alveolar airspace into the smooth muscle cell of the bronchioles and of the endothelial cells in the smooth muscle of the vasculature. Converts the guanosine triphosphate to cyclic GMP upon activation of guanylyl cyclase. And that, through a series of protein kinase-mediated cascades, inhibits calcium release, as I mentioned earlier. And when you inhibit that, you don't have calcium available for the sarcoplasmic reticulum to release it for use by myosin, and the whole cell kind of relaxes. So this is all occurring right here within the endothelial cell of the perialveolar capillaries. Again, another image that shows you how nitric oxide gets oxidized in the presence of alveolar oxygen to nitrogen dioxide. That's what nitrogen dioxide is. In addition, it enters the circulation, gets inactivated by hemoglobin, okay? And as we said, can cause methemoglobinemia when it artificially oxidizes the iron atom within the porphyrin ring. And in this image, what we see is the formation of that nitrosyl hemoglobin. Okay, so nitric makes its way out of the alveolus over here into the intravascular space, into an RBC, binds to hemoglobin, and it creates an oxidized form of hemoglobin, which is, of course, methemoglobin. Again, it can form nitrogen dioxide in the presence of molecular oxygen, and that can go on to get further oxidized into nitric acid. Okay, that's the nitrate form of nitric acid. So this is the typical monitor that you see when you're employing the use of inhaled nitric oxide, and you can measure the dose that you're giving in parts per million right here of nitric. And as I said earlier, you can also track the concentration of nitrogen dioxide in the exhaled effluent. So that helps you define the rate-limiting dosage of nitric oxide. If this number is starting to increase appreciably, then you're sort of limited in your capacity to use this drug. Otherwise, you're going to incur significant alveolar injury. So a variety of clinical trials of inhaled nitric oxide in patients with ARDS didn't demonstrate any effect on mortality or the duration of mechanical ventilation. However, at the 6-month mark, patients with ARDS who had survived after treatment with low-dose inhaled nitric had significantly better values for selected pulmonary function tests. So that's the best that we've been able to show with inhaled nitric for the treatment of ARDS. We're going to move on to nebulizers. Nebulizers basically humidify respirable gases by generating aerosols containing droplets of water from a reservoir of water. Now, that water may additionally contain medication. Okay, there's 2 types of nebulizers: gas-driven or ultrasonic. Okay, with gas-driven nebulizers, you're essentially employing the Bernoulli principle. Okay, it's basically a force-driving gas under pressure to entrain water from a reservoir. Okay, so you have sort of a reservoir of water, and there's high-velocity gas flowing past it, which basically creates a little bit of a vacuum on the surface of the water, which helps entrain water molecules into the gas phase, basically trapping them within the gas flow stream, and that basically delivers it to the patient as they inhale. And as I said, if there's medication in there, we'll take that with it. So water is sucked into that gas system and broken up into droplets by the high velocity gas flow. And so this is what you see here, gas-driven nebulizers. Here's the reservoir of water, and here's the driving gas supply. As that gas supply comes in at a super high velocity, okay, it creates a relative vacuum around this area here. And because there's a vacuum there, the vapor pressure of the liquid level drops, and water molecules vaporize into the gas phase. And they take their medication with them and sort of stream out across this anvil to the patient who's inhaling. Ultrasonic nebulizers use the process of sonication to nebulize water and other solvents. There's a plate containing a piezoelectric crystal. Piezoelectric crystals are basically membranes that deform, and when they deform, that's a form of energy that gets converted into an electric current. Okay, that's essentially what that is. And these crystals vibrate at an ultrasonic frequency around 2 megahertz, very fast. And when they do that, water is dropped onto that plate, or the plate is placed into water. Those high frequency oscillations cause the water to break up into droplets. Okay, and gas flowing into that nebulizing chamber picks up the droplets to deliver them to the patient. Okay, so really high quality diffusers can use this technology to do this. Okay, it's a very effective way of nebulizing water. And this is what we have, okay? So patient's inhaling here, and you have this piezoelectric crystal oscillating at a very high frequency, 2 megahertz. And as water enters here, it basically just, for lack of a better term, it gets the crap beaten out of it as it lands on this high-frequency oscillating piezoelectric crystal and just gets busted up into vapor molecules that the patient inhales. So, with nebulizers, the deposition depends on the size of the droplets. And droplets with a diameter greater than 5 microns are deposited in the upper airways, okay, and that's due to gravitational settling. Droplets with a diameter in the range of 2 to 6 microns are deposited in the tracheobronchial airways, and droplets with a diameter of about 0.5 to 3 microns are deposited in the alveoli, okay. And so, since you get a range of droplet sizes, you can impact the entire tracheobronchial tree. To move on to echocardiography, again, this is not going to be a comprehensive lecture on echocardiography for the purposes of certification, for cardiothoracic anesthesia. That's entirely separate if you do a fellowship there. What I want you to focus on for the Part 2 exam, we'll go over some basics of echocardiography and some images to show you how we assess the anatomy, but probably your best resource is to go to the University of Toronto website, and they have a virtual TEE program and a virtual TTE program, which really helps dissect the heart along every imaginable plane, and certainly every standard imaging plane that we use for a 20-image, 20-plane comprehensive echocardiogram exam for TEE. If reorienting three-dimensional anatomy is not your strength, this is worth doing because it shows you the anatomy that's dissected and the corresponding echo image alongside it. And the reason for doing this is not only to become adept at it clinically, but like I said, the ABA is going to give you ultrasound images in real time. They will do it for the ABA exam. They will also have an entire station for the OSCEs for the applied exam, the oral exam, utilizing real-time echocardiography. So it is definitely worth knowing, even for the generalist, how to interpret all of this, okay? Know what's normal, know what's abnormal, look for obvious pathology like pericardial effusions, regurgitant versus stenotic lesions, and hypokinesis or dyskinesis of the walls. These are basic things that you should be looking for. So with echocardiography, an ultrasound beam is continuously or intermittently applied sound waves that are emitted by a transducer, and it's composed of density or pressure waves that can exist in any medium with the exception of a vacuum. Ultrasound waves are characterized by their wavelength, frequency, and velocity. Wavelength, of course, is the distance between two nearest points of amplitude of equal pressure or density in an ultrasound beam. As the waves travel past any fixed point in the ultrasound beam, the pressure cycles regularly and continuously between high and low values. The numbers of cycles per second, or hertz, is called the frequency of the wave. So ultrasound is sound with frequencies above 20,000 hertz, which is the upper limit of the human audible range. So again, piezoelectricity is employed in this technology as well. Piezoelectric crystals convert the energy between ultrasound and electrical signals. When presented with a high-frequency electrical signals, these crystals produce ultrasound energy, which is directed towards the areas to be imaged. An ultrasound signal is emitted from the piezoelectric crystal. After the ultrasound wave formation, the crystal listens for the returning echoes for a given period of time and then pauses before repeating this cycle. Okay, and that's what this image down here shows you. Okay, you have the primary waves and the reflected waves, which the receiver interprets. So, know these terms. M-mode echocardiography is the most basic form of ultrasound imaging. In this mode, the density and position of all the tissues in the path of a narrow ultrasound beam, basically along a single line, are displayed as a scroll on a video screen. Okay, and this is what you can do across a valve, for example, to show the velocity of flow, for example. Two-dimensional or 2D mode ultrasound is what you're more commonly used to, with rapid repetitive scanning along many different radii within an area. The shape of a fan or sector can be imaged. Echocardiography generates a 2D image of any section of the heart or any anatomical cross-section that you'd like. Okay, and this is what you're most commonly used to. So chamber views that you should definitely be aware of for the Part 2 exam. A 4-chamber view, the most basic view in the world, and you're going to see, like I said, all 4 chambers here. And what you have here is where the probe is positioned in the esophagus to section the heart. Here's the actual anatomic section, and here's the corresponding ultrasound image. Okay, and this is obtained by slight advancement of the probe from the 5-chamber view, which if you sort of pull it up a little bit, you'll actually capture part of the LV outflow tract and the aortic valve. So both the atria and the ventricles, as well as the anterior mitral and posterior mitral leaflets are imaged, as well as a tricuspid valve is seen in this imaging plane. So, as I said, the 5-chamber view, it can be obtained, and in this case, as you can see, between the 4-chamber view up here and the 5-chamber view, sort of tilted up a little bit, and in the process, you've come up cephalad and you're capturing the aortic valve cusps right here. Okay, and that's what was known as the 5-chamber view. The 5th chamber is essentially the LV outflow tract. As you can see in the corresponding ultrasound image here, you can see these 2 leaflets of the aortic valve. And you can assess this for aortic stenosis or regurgitation. You're also, in this particular image, capturing the chordae tendineae latching onto the mitral valve leaflets. Now, the 2-chamber view, very simple concept here. You start with the 4-chamber view up here, but then you rotate the angulation of the beam 90 degrees, so you're slicing the sagittal section right there. And as a result, you're cutting along the heart, along this plane that you see, okay? And so what you have here is the LV and the left atrium, and you're actually going to be able to view the left atrial appendage nicely in this setting, okay? And that's what that is over here. So you can assess for left atrial thrombus in this image plane quite nicely. So if they ask you a question about which imaging plane is most suited to checking for the presence of an atrial thrombus in the setting of atrial fibrillation, for example, mid-esophageal 2-chamber view is ideal. Okay. Now you have your transgastric view. Okay, so as you can see, the ultrasound probe is you dive pretty deep with this, and then sort of fold back with your angulation, and that gives you a cross section of the heart that looks like this. Okay, when you see only the ultrasound image on the exam, it's hard to sort of make heads or tails of this. So you sort of have to reorient this a lot, and that's why I included this nice picture here, because it really does point everything out nicely. And when you re-image it here, you have to understand what's right and what's left, so forth. This is the aorta right dead center. Here's the right atrium over there. Okay, and you're actually cutting right through the right ventricle all along through here with the pulmonic valve up there. So that's what this is. Okay, and since your imaging plane is fanning out from here outward, okay, your pulmonic valve is actually down here. Okay, so this is all right ventricle, this is your pulmonic valve. And that's what throws people off oftentimes, because when you look at the 4-chamber view and the 2-chamber view mid-esophageal 4-chamber and 2-chamber views, everything is sort of aligned the way you kind of see it anatomically, but once you get to the transgastric views, your probe is flipped backwards. And so everything that's towards the apex is at the top of the screen. Everything that's at the top of the heart is at the bottom of the screen. Okay, so I would just look at this over and over and over again, sort of memorize it, so you understand where you're oriented and you don't get tripped up on the exam. So you can do a transverse cut through the aorta and the pulmonary artery. Okay, and as you can see, your probe is pretty high up in the esophagus, and it's just slicing through the top layer of the aorta. Okay, and so that's what you're cutting through. Okay, and so when you sort of rotate this and you can see all these different sections of the heart that you're cutting through, you get this kind of image on the ultrasound. And if you compare it to the previous slide, I mean, this doesn't look that far off, and it's real easy to get tripped up on this, and you're like wondering, what the heck in the world am I looking at? I know this is a valve, but what valve is it? But as you can see now, everything is reoriented back in the normal plane that you're used to, meaning it's fanning out in the superior-inferior direction. Remember that transgastric view, everything's flipped backwards. Now, you're going back in the normal direction. Here's your pulmonic valve and PA. Here's your aortic arch. Now here's the same thing, transverse cut through the aorta and the pulmonary aortopulmonary window, but what we've done is we've rotated 90 degrees, okay? And so now we're slicing 90 degree sagittal plane through the aortic arch right here, and that's what you have here. It's pretty readily identifiable. When you see this cusp sitting right here on both sides, you know you're pretty much looking at the aorta, so that should help reorient you, okay? So those were the basic views that I think you should definitely look over. I don't know if you necessarily need a comprehensive understanding of the full TE exam for the Part 2 exam, but I think because it's coming your way for the oral exam and for the OSCEs, it's probably worth reviewing at a regular interval so you understand the image planes that you're looking at. On to pacemakers. So I think you're probably aware of the different nomenclature for pacemakers. Position 1 is the chamber pace, position 2 is the chamber sensed, and the third position it basically refers to how the pacemaker responds to a sensed event. Okay, so there's a lot of different letters involved here. It's a little bit of alphabet soup, but A is atrium, V is ventricle, and D is dual. That's pretty straightforward. Okay, in position 2, there's an additional option. You can have the letter O, and that basically indicates an absence of sensing. Okay, in this mode, okay, basically if there's a letter O in that second position, the pacer is actually doing all the work. Basically, it's ignoring any sensing. Okay, so it doesn't care what the heart is doing, and it's going to do all the pacing. Okay. So that's essentially what that O means. Okay, now position 3, there's this I that refers to inhibited, okay? And that's a little, sometimes it confuses people. The idea behind an I for the position 3 to inhibit the pacemaker is that it will inhibit the pacer when and only when if the native rhythm is viable. So it will always be detecting the patient's native rhythm, and if it looks like everything's good to go, it'll inhibit the pacer. But if the patient trips up and there's too much of an AV delay or something, the pacer will do the work of pacing the patient. Okay, so that's essentially what the inhibit means. You rarely ever see the T, the triggered setting for the third position. I can't think of a time where I've seen that. So I wouldn't worry about that too much, but the idea is that it will trigger the pacer. Dual, D for dual mode, basically refers to dual chamber systems, and an event is sensed in the atrium which will inhibit atrial output but triggers a ventricular output. Now, there's other letters involved, other positions involved. Rate responsiveness, or as otherwise known as rate modulation or rate adaptation, refers to the ability of a pacemaker to adjust its programmed pace rate based upon patient activity. So it can track oxygen consumption, CO2 production, things like that, to ramp up a heart rate, the paced heart rate if need be. If the patient happens to be exercising, whatever. Okay. And biventricular pacing is something you should be aware of as well. Most pacers, simple pacers, have a lead in the right atrium and the right ventricle, and pace the sinoatrial node, the AV node. But you may need a pacer wire into the left ventricle if you want to achieve full synchrony of the two ventricles contracting with each other in concordance. Now, you can't perforate through the septum to get that lead there. What you do is the cardiologist actually places the lead through the right side of the heart into the coronary sinus, okay? And it basically leaves it there on the coronary sinus because that can track over across the septum into the left side of the heart, left side territory, and pace the left ventricle that way. And this is pretty much 100% of the time used for cardiac resynchronization therapy to make sure the two ventricles are contracting at exactly the same time, which improves overall cardiac remodeling in patients with a history of congestive heart failure. So let's go over some settings. Ventricular demand pacing, okay? Understand what these terms actually mean, okay? In a setting like this is VVI, okay? So ventricle paced, ventricle sensed, and the pacemaker is inhibited in response to a sense beat, okay? This is one of the most commonly used pacing modes. Now, I really hate this term ventricular demand pacing. It sounds to me initially like, oh, you're demanding that the pacer do all the work. It's actually not true. What it means is that you're demanding that the pacer do the work if and only if the patient can't get it done on their own, okay? And so that's why that last letter is I. It inhibits the pacer so long as the patient's doing fine on their own. So this is not a setting that you would use in someone who's entirely pacer dependent, okay? This is someone who may need occasional pacing, okay? So that's what is referred to as ventricular demand pacing. The advantage here is that you typically only need one single lead and the ability to protect the patient from dangerous bradycardias of any etiology because you only expect the pacer to do the work when they brady down. It doesn't maintain AV synchrony. Nothing does that except for a dual chamber pacer. Okay. VVI pacing is primarily indicated in patients with chronic atrial fibrillation with a slow ventricular response. AAI, very similar to VVI, okay, this is atrial demand pacing. You don't see this too often, but basically you're pacing the atrium, which is being sensed, and the pacemaker is inhibited so long as the atrium is doing its job, okay? And this is basically used for patients with sick sinus disease or sinus node dysfunction who have an intact AV nodal function, okay? You're rarely going to ever see this, okay? The idea is anybody who develops sick sinus syndrome probably has a disease process that's eventually going to affect their AV node. So a single lead pacer in the atrium is not something you're going to see very often. If they're going to do the work of putting a pacer in, they're most likely going to put a dual lead, one in the atrium, one in the ventricle. And they can just change the setting to incorporate the AV node in the ventricle at any time if the patient only has isolated sinoatrial disease. Overall, I just wanted to include this so you understand what AAI is used for. Dual chamber pacing systems, RA and RV, may utilize the DDD pacing method. This is the most comprehensive pacing program you can pretty much have. Okay, the pacemaker can do either or, trigger or be inhibited. Both chambers can be sensed and paced or not, or just one or the other. Pacemaker will be totally inhibited in the presence of intact sinus rhythm with normal AV conduction. So patients doing everything on their own, pacer doesn't do anything at all. Okay. Overall, if there's sinus bradycardia but normal AV conduction, then the pacer will just pace the atrium. If both the atrium and the ventricle are affected, pacer will pace both of them. So, you can't go wrong with this. It does virtually everything. So, with DDD programming, there's 4 possible permutations that you can get. With normal sinus rhythm, you have complete inhibition. This is the patient's own native rhythm. If a patient has sinus dysfunction but intact AV nodal function, the pacer will just pace the atrium right here, and the patient's ventricle will do their own thing. You can have AV sequential pacing when both the atrium and the sinoatrial node and the AV node aren't working properly. And then lastly, if the atrium is working fine with sinoatrial node function, but the AV node is problematic, you can just pace the ventricle. So you review these rhythms with the pacing spike so you understand what's happening, but you can get any one of these 4 rhythms coming out of a DDD program. And lastly, anything with 2 O's at the end. Okay, this is what's called fixed-rate asynchronous pacing. Okay, it's asynchronous because it doesn't necessarily get concordance between the right and left ventricles. Remember, for that, you need a dual chamber pacer. You need that extra lead in the coronary sinus to capture the LV. We're not talking about that. We're only talking about the most common dual lead pacers in the right side of the heart. So this is called fixed rate asynchronous. These are settings where the pacer does all the work. It ignores the patient completely. Okay, this is the setting that you put your patient on when they come to the OR, and there's a risk of pacer dysfunction because the site of surgery is very close to the pulse generator, and they're going to be using cautery or something like that. Okay, so they're doing a mastectomy on a patient who has a pacer. You would put them in AOO, VOO, or DOO. Usually DOO because the patient's most likely to have a dual lead pacer. Okay, and remember, in that case, both chambers are paced Nothing is sensed, okay? Nothing's inhibited. Basically, both chambers are paced all the time. So this O in the second position means that the pacer is ignoring both chambers, okay? It doesn't care what they're doing. It's going to continue pacing them regardless. It's going to do all the work of pacing, okay? Asynchronous pacing modes aren't really used long term, but they can be if the patient is entirely pacemaker dependent, okay? You can get competition between native and paced rhythms, the possibility of a paced impulse occurring on a native T wave. So to reduce that risk, asynchronous pacing is usually programmed to a relatively higher heart rate, around 80 beats per minute. And that's why your patients, when they're reprogrammed by cardiology to DOO, VOO, whatever, they're usually placing around 80 to 85 beats per minute. They want to just keep the patient with a heart rate fast enough so that they avoid pacing right on a native escape rhythm. Lastly, transcutaneous pacing. This can work in an emergency. It's not the most effective way to pace someone. There's a lot of issues. The inability to achieve capture is one because of the impedance of the chest wall or inadequate adhesion of the pads to the patient. Using paddles is far easier, but that's usually when you need to defibrillate or cardiovert. Usually don't keep them on just to pace someone. And patient discomfort is sort of significant here. In order to overcome the higher impedance, you need higher energy levels, which can make things uncomfortable for a patient. So hopefully that was a reasonable overview of some of these extra keywords that have been added over the past few years to the advanced exam. Thanks for listening.